everyone, my name's Sarah and today I'm going to be taking you through a quick overview of peptic ulcer disease. This presentation has been put together using the Elsevier Clinical Key resource. We're going to start off with a case study. So a 68-year-old woman presents to the GP with burning epigastric pain for 2 months. Further questioning elicits weight loss, the abdominal pain comes on after meals, and it occasionally comes on at night and has sometimes kept her awake. She has a past medical history of osteoarthritis and has been smoking half a pack a day for 10 years. On examination, she appears pale with conjunctival pallor. So what stands out in this case? There are several things that scream sort of peptic ulcer disease. You've got the burning epigastric pain, there's weight loss and pain that's coming on after meals. It comes on at night on occasion. And she has a history of osteoarthritis, which might lead you to think that she's been taking NSAIDs for it, and she's been smoking as well for a relatively long time. And then additionally on examination, she's pale with conjunctival pallor, which might be suggestive of anemia. So that leads us nicely into peptic ulcer disease. That was a relatively classic presentation. So peptic ulcer disease is an erosion of the gastric mucosa that results in damage of the underlying tissue and the development of these painful sores in the lining of the stomach. It is the most common cause of upper GI bleed in the UK, which is an important fact for you to note. In terms of presentation, this can be split up into signs and symptoms. Signs will often be this burning, sharp epigastric pain, nausea and vomiting, symptoms of bleeding as well, so hematemesis, often coffee ground vomiting, and also then melena as well, so traces of blood in the stool. Reduced appetite as well with concurrent weight loss can also be seen in certain types of peptic ulcers. And then also symptoms of anemia like fatigue and shortness of breath on exertion, etc. Signs of peptic ulcer disease can be signs of upper GI bleeding if you've got someone who presents with an upper GI bleed secondary to peptic ulcers. Epigastric tenderness as well on palpation of the abdomen, and then also pallor if anemic and other signs of anemia. What's important for you to also keep in mind in terms of exams is what is the difference between the duodenal ulcers and gastric ulcers, apart from location. Duodenal ulcers classically present with pain that's relieved by food, whereas gastric ulcers, the pain is exacerbated by food. Important to note as well is that duodenal ulcers are less likely to be malignant than gastric ulcers, but they are also more associated with Helicobacter pylori. They also occur around 10 to 30 years earlier than gastric ulcers, and nocturnal pain is more likely for duodenal ulcers. In terms of gastric ulcers, they are more associated with NSAIDs, so use of non-steroidal anti-inflammatory drugs. And although nocturnal pain is less likely for gastric ulcers, it can still occur. So in our case, we are looking at someone who's presenting with something that's more likely to be a gastric ulcer because she has pain that's exacerbated by food. She's likely on NSAIDs given her history of osteoarthritis, and she's also getting nocturnal pain. In terms of risk factors, there are quite a few risk factors associated with peptic ulcer disease, but the main ones are age, so increasing age, use of NSAIDs as mentioned, and also steroids. Infection with Helicobacter pylori, this is because it causes chronic gastritis, which then, so essentially chronic inflammation of the gastric mucosa, which then predisposes to peptic ulcer disease. Additionally, anything else that causes chronic gastritis is believed to also be a risk factor for peptic ulcer disease. This also includes tobacco, so smoking, and also alcohol consumption, which are also believed to be associated with this. Rare associations with peptic ulcer disease are Zollinger-Ellison syndrome. And we'll talk a bit more about Zollinger-Ellison syndrome in a bit. The pathophysiology of peptic ulcer disease can be boiled down to essentially damaging factors against the gastric mucosa outweighing the endogenous protective factors. Damaging factors are hydrochloric acid, so gastric acid, pepsin, the urease enzyme produced by Helicobacter pylori, NSAIDs, alcohol, and tobacco, which are of course risk factors as well. In terms of protective factors, you have the surface mucus layer, which serves as a physical barrier, apical membrane transport, and the production of bicarbonate to balance out the acidity of gastric acid, prostaglandins as well, mucosal blood flow, and epithelial cells, which all help to protect the stomach lining. The investigation and the management of peptic ulcer disease can be essentially split up into two sections if an individual is bleeding actively or if they're not. So if someone isn't actively bleeding, the first investigation is typically a Helicobacter pylori breath test and or stool antigen. This is often done after they've been trialed for 1 month with a PPI. To note is that with the H. pylori breath tests, they must stop their antibiotics 4 weeks before taking the test and stop PPIs for 2 weeks before the test. This is because they can produce false negatives if a patient is still on antibiotics or PPI closer to the day of the test. Something that isn't routine but can still be done is upper GI endoscopies and biopsies. Now, if you have someone who's presenting with a gastric ulcer or a history of a gastric ulcer, you're more likely to then undertake a endoscopy with a biopsy because they are more likely to be malignant, so it's important to pick that up. If you have someone who's presenting with recurrent peptic ulcer disease that doesn't seem to be going away under regular management, you'd then consider doing fasting gastrin to then see if you can diagnose Zollinger-Ellison syndrome. If someone's actively bleeding, the first line investigations include bloods, so full blood count to assess whether or not they need a transfusion and the severity of their bleeding as well. Urea and electrolytes are important. Urea, if raised, is more likely to then indicate a upper GI bleed as opposed to a lower GI bleed, and additionally helps you assess if there's any pre-renal acute kidney injury. LFTs and coagulation, so baseline liver function and also coagulation, because that will then impact the severity of the bleed, and then also venous blood gas. Imaging is important here as well. Upper GI endoscopies and biopsies are done because they're diagnostic and therapeutic. But if you suspect a perforation, an erect chest x-ray is always an essential part of imaging to diagnose that as quickly as possible, because those individuals then need to have emergency surgery. One of the things to be aware of in terms of investigations of upper GI bleeding is the Glasgow-Blatchford score. I don't think you need to memorize it in extensive detail for your exams. Just be aware that the score, if above 0, a patient needs to be admitted for inpatient endoscopy. Components of the score are hemoglobin, urea levels, their initial systolic blood pressure on presentation, the sex of the individual, if they're tachycardic or not, and then if they've got a history of syncope, heart failure, or liver disease. So management, as mentioned as well, can also be split up into those two categories. If a patient is not actively bleeding, the first line management, as with most things, is conservative, so you manage the risk factors. And then typically they'll be trialed with 1 month of a high dose PPI, usually omeprazole. This is either if they've been tested for Helicobacter pylori or if their test has come back negative. If their test is positive, then Helicobacter pylori is treated using triple therapy, so that's 2 antibiotics, typically clarithromycin and amoxicillin, and then also 1 PPI, typically omeprazole. Second line management depends on what they've been given already. So if you have a patient who's only been trialed on 1 month of PPI, then you'll test them for Helicobacter pylori and then move on from there. If a patient is actively bleeding, first line is always fluid resuscitation if it's needed, so IV NaCl usually, a blood transfusion if it's necessary. Upper GI endoscopy is therapeutic as well as being diagnostic, as mentioned. So typically the management here is either one of clipping plus or minus adrenaline, thermocoagulation with adrenaline, or sclerotherapy with adrenaline. Importantly, adrenaline should never be given on its own. High-dose IV proton pump inhibitors are given after endoscopy. They should not be given before because they can mask the site of bleeding. And second line is surgery or embolization if the first line management is not successful. Three main complications to be aware of with peptic ulcer disease are perforation, gastric outlet obstruction, and a malignancy. Gastric outlet obstruction occurs usually in chronic ulcers near the pylorus. After a certain amount of time, you'll get fibrosis and scarring of that ulcer, which will then cause it to bulk up and obstruct the pylorus. And that usually presents with extensive vomiting, nausea, bloating, things like that. So a very quick run through of perforated peptic ulcers, because it's an important emergency presentation you should be aware of. Typically it presents on a background of peptic ulcer disease or with a concomitant history of peptic ulcer disease with sudden onset abdominal pain, tachycardia, and abdominal rigidity or peritonism, which are red flag symptoms for, which should really raise alarm bells. An erect chest x-ray is done and it will show pneumoperitoneum. In terms of further imaging, an abdominal x-ray is then preferred as first line to try and locate the site of perforation. If it can't be determined using a abdominal x-ray, they'll then proceed to a CT scan. The most common area or site of perforation is the anterior wall of the duodenum, of the first part of the duodenum. So duodenal ulcers are more likely to perforate. And finally, a very brief note on Zollinger-Ellison syndrome. It is a gastronoma or a neuroendocrine tumor. Essentially, excess gastrin is produced by the gastronoma, which then causes excess HCl secretion, which causes both peptic ulcers and malabsorption, because the increased acidity of the contents then in the duodenum as it passes from the stomach inactivates pancreatic enzymes. Diagnostic tests for this is the serum gastric level, which is, if above 1000 picograms per milliliter, is diagnostic. Zollinger-Ellison syndrome is part of MEN1, which is multiple endocrine neoplasia type 1. 60% are malignant, but it's a very slow growing tumor. So, thank you very much. That was your quick run through of peptic ulcer disease. I hope that was helpful.